land grant, Midwestern University, where education was paid for by giving the schools land, which they could utilize to make money to pay tuition or to sell. And we still benefit from that today as you look at some of our research hubs, which are built on the old farms, the university farms. Our topic today is by Dr. Long from Anesthesia and Medicine. This is really important. This is what happens to our patients after major disease. So post-ICU syndrome is really a subset of all of our patients, because there are very few things in neurosurgery that aren't life-changing for that patient. And what is their life like afterwards, and what is it like to survive a near-death experience is very important, besides the obvious medical parts that go into post-ICU syndrome. So medically and mentally, it's very important. We're really thrilled that you're here to be.
Thank you.
Thank you very much.
Thank you for having me. I realized I made the first typo right out. I'm not an associative professor. This is terrible. Sorry about that. So I wanted to just start out and say thanks to everybody for all the availability all the residents have and the faculty. As most of you know me from the surgical ICU side, and I know we have a lot of questions as non-brain doctors. So I'm very thankful for not only you guys always being there for your patients, which is obvious as clinicians, all of us are that way, but you're there for me and my team, and I'm honored to be here because of that, and thank you very much. Post-intensive care syndrome, I don't have any relevant disclosures, is a really important topic that I don't think we talk about all that much. And some of the reason we don't talk about it is because all of our medical training focuses on the cool, sexy, life-saving things we do, right? When you can operate on somebody or make a good clinical decision, come up with whatever right antibiotics it is, whatever area you focus in, what we talk about and focus on is making that right, quick decision that saves somebody's lives. And I think most of us can remember back in undergrad when we thought, we wanted to be a doctor, and that sense or desire to save people is really important to us. But when I think of what a patient goes through being saved, it's actually very similar to being abducted by aliens, right? So in a big car accident, you're kind of with it. Some big stressful event happens, you're completely out of it. You wake up in a place you've never been with people in like COVID garb, right? All covered up. And in the midst of them covering it up, they put tubes in every spot that are not supposed to be there. We put you to sleep, but you're not really sleeping. You're in a coma, and then you come out and you're delirious. All our drugs make you hallucinate. And in the midst of this hallucination, you might see grandma who died many years ago, and you might, have all these frightening things happen to you. And then finally you come in and out and are awake. And that's really not that different from alien abduction. And then after that, there's a whole long phase of things. Now, as an anesthesia intensivist, I'm like so done with patients the moment they're out of my ICU. You guys, of course, take the next step and follow them for quite some additional time. But from a patient perspective, the cost of ICU is not days or weeks of a hospitalization. It's lifelong and months long as a best case. And there's a whole history of how we came to learn how impactful critical care was. But I'll sum it up by saying it really isn't that dated of a field. The first reports of knowing that patients were having brain dysfunction after ICU came out in the late 80s. And in the 90s, we learned that patients were having really huge psychiatric struggles like PTSD after intensive care and critical illness. And then, of course, all of us knew about weakness, but learning how that impacted people's ability to go back to work took quite some time to figure out. And that's what PICS is. It has those three big categories. One is the physical things, second is the brain things, and the third being the psychiatric or psychologic aspects of what happens. But what we're learning, particularly in the last 3 to 4 years, is that all of these things overlap into this complex metabolic profile of people that have critical illness. And everybody learns, particularly in neurocritical care, all of your adrenal problems that happen, our post-TB meningitis, adrenal insufficiency is, a classic textbook. But a whole bunch of our patients end up with like gonadotropin-releasing hormone deficiencies, right? So they're 6 months out from critical care. They might need testosterone supplementation. at their primary care or PICS follow-up sort of area. And all these things overlap, which is really obvious. If you're really weak and you feel terrible, you're not going to exercise. If you don't exercise, you might end up more frail and less active. And that overlaps to sleep and how you feel. If you're not sleeping because you're having nightmares from PTSD, you may avoid the doctor, all these things. So this overlaps greatly. But for the purposes of today, I want to focus really closely on the three big categories of physical, the brain, and the mental health aspect. And I want to emphasize a little bit delirium. And delirium is a really, really important thing that I think I blew off for a long time. So my main goal today is to teach you a little bit about delirium and how that plays a role. But before I get to delirium, ICU acquired weakness, I do medical critical care, was kind of my first love of critical care. And ICU acquired weakness is one of the major problems we see in our older population that end up in the medical ICU. Now, ICU acquired weakness, we all understand it a little bit. You know, fundamentally, we know grandma that gets pneumonia and comes in. When she goes home, she's weaker. I think fundamentally, we all understand this because everybody's been sick. And if you're an athlete or jog or do any sort of exercise, and then you get a real bad cough and you're out for a few days, you know, when you go back and do a jog afterwards, it's a dramatic drop off, right? Everybody knows this. What happens in the ICU is that times 100-fold. It's a really important thing. And there's physiologic underpinnings to it, not only at the nerve level and endocrine level, but of course at the muscle level. And we have things that put people at risk of this. They're really obvious, right? If you're not active, you have less muscle at baseline, you're older, these things play a role. Of course, the inflammatory part of critical care plays a huge role. So the sicker you are, the more inflamed you are, the more the nerves and muscles are impacted. But there's things we can do about it. In the intensive insulin and tight glucose era of critical care, this was hugely talked about, that this would be life-saving. And it does help people, but really in the extremes. One of the things that we will start reading about in the next 6 to 12 months is going to be the COVID-induced ICU-acquired weakness, because we used tons of steroids and we used tons of paralysis to get people through COVID. And they will start to come out and be like, hey, I got better and I was weak, and it's maybe not long COVID, whatever that phenomenon is, but I'm fundamentally different. I'm not as active anymore. But one of the core things that we do really badly is leave people immobile. And this is not only for paralysis, but it's basic range of motion things make a huge difference in whether people lose their muscle. And the underpinnings of it are really broad, but being immobile essentially activates a whole bunch of proteolytic enzymes in your muscle. And so you lose all of your muscle. If you lose, of course, testosterone and gonadotropin related hormones, you're going to lose muscle. And that's combined with decreased function at the level of ischemia reperfusion, struggles at the mitochondria that don't recover over a long time, and just inflammatory induced cellular necrosis. This is a picture of a diaphragm. And the control cases are lung cancer patients or thoracic surgery patients, they're mostly lung cancer, who agreed to let the surgeon do a biopsy of their diaphragm in the case. And the ones on the left are brain dead donors who, after the decision to donate, had a diaphragm biopsy taken. And you can tell they're different. I don't know if anybody does muscle stuff in here, so forgive me. I don't know how to read this. But what I know is that they're different. And when you read the report, and this is old, right? This is 15-year-old data published in New England Journal, is that the muscle fibers are all lost. It's not just fast twitch, slow twitch, they're smaller. And then all that followed after this was that there's not only a problem with the muscles themselves, there's a problem with the nerves that innervate it, and there's not only a loss of tissue, but the tissue that's there doesn't contract as well. And this is in the diaphragm. Of course, our periphery, this occurs in as well. What I've been alarmed by, and we track diaphragms now with ultrasound, there's some pretty good research about this, is that this diaphragm wasting occurs as soon as 12 hours after you intubate and paralyze somebody. So if they're breathing, it takes longer. But if you have a non-awake intensive care patient on a ventilator, within 12 hours, their diaphragm is weak. The old teaching was, let their diaphragm rest. They've been, working so hard to breathe for a while. We should give it time, kind of like if you run a marathon, you need to take a break. That might be really terrible for you, but certainly after 5 or 7 days, waiting for strength to recover is is a fool's errand. When we look at how this impacts people, the ADLs are profoundly impacted. And what I will repeat over and over again in this talk is how sad it is that people don't get better in the 3 to 12 month window. So a quarter of people having instrumental ADL deficits, basic ADLs right around the same at a year, but there's not this remarkable, like, 3 months to 12 months, I started doing CrossFit, that sort of craziness. Of course, this impacts our actual hospital outcomes. So if you're weak, you can't get off the ventilator, you're more likely to get a trach, you are more likely to get second infections and not actually recover from the ICU, and it impacts our mortality. And one of the biggest things we can do is actually just keep people moving and do passive range of motion. I'll bring up a study later where University of Chicago just did basic PT. They had a team of PTs that came in and did passive range of motion. And in ventilated patients, they sat them on the edge of the bed, and if they got better, they let them stand with a ventilator. Really basic, not advanced, not walk around with a vent. And they had improved outcomes, not only on the short term, but the brain outcomes were better in this group just because they were moving. Now, of course, the physical aspects go beyond strength. We have a whole bunch of things that happen procedurally and that happen that we kind of understand, but not super well. Like if you have a breathing tube in and you're not eating for months, your fundamental sense of taste is altered forevermore. And so patients will sometimes say, I don't want to eat. It all tastes terrible. And then they can't, get nutrition. They can't exercise, all these things. Heterotopic ossification occurs with alarming frequency if you read case reports. As an intensivist, I should know patients that this happened to, but they're all kind of out of sight and out of mind. But in the really profoundly inflamed patients, that inflammatory process occurs, in the soft tissue surrounding bone. And so the images in the top and the bottom left are essentially calcification of all the tissue surrounding it. So if you imagine, you're not only really weak, but now you have to move a concrete joint, it doesn't work very well. So physically, ICU is terribly stressful. The brain stuff we learned about again, really in the 90s, but the absolute best study came out of Vanderbilt, and Vanderbilt has a sister hospital, one of the Catholic hospitals, the name is escaping me, in Nashville. And they do this really good follow-up work after critical care with essentially a team of psychologists that call them up and do screening questions. And they did this study, it's called the Brain ICU study. This score, the cognition score, is similar to the IQ, and it's zeroed accordingly. So at 0, your average is 100 and standard deviations are about 10. And you can see normal folks there. And in this study, what they did is they took all medical and surgical patients that either needed vasopressors or needed a ventilator. So it's really broadly inclusive, including a lot of patients that aren't that sick. Median length of stay is like 2 days, right? So these are not your worst patients. These are average patients. They excluded anybody on surrogate questioning that may have had brain dysfunction before they got sick. So they did their best to exclude. It turns out I think they had 450-ish patients, a little more than that, that 6 of them they missed. And later on, they found out they had cognitive dysfunction. But rough guessing that your average IQ in this group was about 100, right? So if you just play the means. And what you notice is all the numbers are below 100. These are age adjusted. And it's an incredible decrement in IQ that happens to the vast majority of patients, right? So 40% of people were 1.5 standard deviations below age-adjusted IQ levels post-ICU. And what frightened me about this study is that the improvement was absent. And some patients, of course, got worse, but really no patients got better with this. And this is really frightening to me. There's a few people, there's 2 individuals that come to mind that I've written in blogs and in some books on post-intensive care syndrome. And it's not academic, it's all popular press. One of them was a corporate accountant who would complain afterwards. So she knew her IQ was 128 or something, upper 120s. So a really smart person and does all this Excel spreadsheet and math, and complained that after surviving critical care, she had absolutely no physical symptoms whatsoever, but she couldn't work again because she couldn't focus on the Excel spreadsheet. And her description was very ADD. It was like, I look at the equation and I get it and I know I need to do it and I type in a number and then there's a bird over there. What's going on? What was I doing? Here's the equation. and she never could work again. Couldn't do basic math. It was very ADD. Other folks will have struggles with memory, so important that they can't, remember what they're cooking, and yet others have complex processing or, of course, executive function sort of losses. Okay, it's still working. It went out for a moment. So these decrements were there, and they're long-lasting. This was the original publication. This is the bottom one, which is or actually it's the middle one. I bolded the wrong one, but 1998. And the quote from it is, the patients at this level of cognitive dysfunction forget what to buy at the grocery store. They're not able to follow multi-step commands. So 2 or 3 step commands are hard. They can't remember lists of things, and they forget if they're cooking until the food is smoking and burning. And this is post-ARDS, not brain injury, not brain injured, nothing else, just ARDS. They first appreciated this. This study was done because they noticed the post-ARDS patients had normal lung function. PFTs were fine in this bulk of them, but they couldn't do a 6-minute walk because they get terribly weak. And then they realized that they started asking them more about their weakness, and it turns out they had all this brain dysfunction. It's a frightening thing as an anesthesiologist to throw a brain scan up in front of anybody, so I kept it really simple. This is from the Visions trial. It took in this same sister hospital, so Vanderbilt and one of the hospitals in Nashville. They took, I think, 47, somewhere upper 40s, number of these same group of patients, right? Medical, surgical, either vent or pressor, and they did MRIs. And this picture was a highlight of their data, and this is 2 different people. One is a 42-year-old woman, that's the one on the left, and the one on the right was 48. They both had viral ARDS, not severe injury. They both got better and medically were matched in terms of ventilator length, ICU length of stay, hospital length of stay, age, comorbidities. They were actually both totally healthy. But the one on the right, where you see you have massive volume loss, had delirium. And this study was done because when they looked at all the risk factors for this cognitive decline, the list perfectly overlapped the risk factors for delirium. And in this study, what they did is they looked at how many days anybody screened the patient positive for delirium. So any single score of the CAM ICU test being positive, they counted. And it ticked you one box farther on the right. And then they looked at brain volumes. And you can see it's a really profound reduction in a whole host of brain areas, but including total brain volume assessments. They took that and did fractional anisotropy, which, forgive me again, as a non-brain person, my understanding of it is fairly poor, but it's essentially a marker of white matter integrity. And as your days of delirium go up, your white matter integrity goes down in core communicative regions of the brain. And as that goes down, your functional outcome goes down, and same with the brain volumes, right? So the more days you're delirious, the more your brain is injured and the worse you do long-term. And what is alarming about this is the lack of plasticity, right? Once you lose this volume, or at least the function, they don't seem to get better over time. And that's the cognitive changes. I think we don't think or talk about them as much because they're kind of out of sight, out of mind. But those IQ decrements, one of my colleagues, one of the anesthesia intensivists that does all CT ICU, his aunt was admitted to the hospital, was another intensivist, and I think she was a surgical intensivist and never could work again. And the way he describes it is like, if you interact with her, you'd have no idea. But I knew her before and after, and we have these big academic discussions about critical care and talk through literature. And then after, it was like talking to like a high school level person, right? They're caring, they're loving, they're fine, they're perfectly capable, but not at the level that you want to be at. Finally, mental health. Now, mental health is a big process, and of course, we know that stressful experiences will make a lot of people struggle. And we see that after the ICU. This is how I got involved in this. I gave you grand rounds a long time ago on a vitamin C related topic. So I've done a bunch of peer reviews on vitamin C. This is a follow-up to the Victus trial. The Victus trial is a multi-center study looking at vitamin C and septic shock, and they were really broadly inclusive and gave a whole bunch of people vitamin C that were not that sick. So the study had a median ventilator duration of 1 day and a mean ventilator duration of 1.2 days, right? So this is a fairly healthy cohort of folks in a lot of patients. And they asked me to peer review this because they took all of that patient group and they looked at their outcomes at 6 months, their cognitive outcomes and their mental health outcomes. And they published the mental health outcomes in JAMA Open. And this is what it was. And when I first did the peer review on this, I said, this is total trash. You have a rate of PTSD that's over 10%. That's impossible. That's crazy. I know it happens sometimes, but come on, 10% of ICU survivors with a median duration of 1 day. And then, hey, look at this. They have way more PTSD, but they're way less likely to get mental health care and get mental health meds. Like, this data is obviously wrong. I actually wrote them a fairly emphatic peer review that was like, this is total trash data. Come on, your secondary outcomes of secondary outcomes. But as I started going through that, I started reading and realized, like, they're not wrong. I'm terribly wrong. The average PTSD rate that they had is the lowest that's ever been reported. In that group of patients, 10 to 15% with a median vent duration of a day, 10% of them or more have DSM positive PTSD at a year. So what we do to patients is really strikingly alarming. This is a meta-analysis of all the studies of PTSD. Prevalence is on the left, all the studies, of course. But on average, again, not a ton of improvement over time, but somewhere around a third at 6 months and a quarter at a year on average. The more sensitive your screen, the more patients you capture, the more you catch, because one of the hallmarks of PTSD, medical PTSD, is avoidance of healthcare, right? I bring PTSD and depression up. This is a study done in England, and they included way more patients. I think it was like 10,000 patients in this trial. So it was UK-wide prospective study of ICU survivors. And the 31% is severe screening. The 69 is mild screen positive, right? So it's not a before, after, or green is not good necessarily. 3 months, 12 months, 3 months, 12 months for anxiety in the top right, and then PTSD in the bottom. So they don't get better, and some people get worse, and it's with intense frequency. And again, it's probably because what patients recall is not different from a really traumatic, completely out of control, crazy dream or alien abduction. I think we underplay PTSD or don't think about it because our bias of PTSD, just because of what we hear about, see, and learn about, is military PTSD, appropriately. But that whole, like, oh, we jump, and if at night they have a nightmare, they might hurt somebody, is not reflective of the full DSM criteria. And the full DSM criteria includes avoidance and depression. And avoidance is truly the hallmark of medical PTSD. And this is really important because then they actually don't go get doctoring, and they avoid telling their docs, like, oh yeah, my breathing is bad, until they come in and need ventilation again. And so the costs go up and their outcomes go down. When we look at risk for PTSD, the most compelling risk identification for PTSD is what the patients remember, and do they remember it terribly, right? So were they really short of breath and we just kind of let them be? We didn't treat it. Did they have horrible vent dysynchrony and they were awake because we do light sedation? That's horrible for patients. The more standardized memories they have, the more likely they have PTSD. And the screen is at 20, it typically overlaps to DSM-4. Now, when we look at this, you see huge, broad error bars, right? And we know this fundamentally. Lots of people have post-traumatic growth, and lots of people have PTSD. And there are people that have one bad memory and huge PTSD scores, and that have a lot and have no PTSD. So there is a huge interplay that goes beyond a stress response. But it's really important because as all of these things overlap, we know that as PTSD patients recover and get out of the ICU, when they're not sleeping, having nightmares, avoiding healthcare, their long-term vitality and general health perception, mental health, all of it goes down. This is one of the original works in PTSD. It was done in a CT ICU post-cardiac for routine cases. Now, routine cases in 2003 were standard admission and 2 days of ventilation. So it's a little different world than we play, a different game than we play now. But the more PTSD you had, the worse you did. When we look at depression, this is a more recent work, and standardized their estimated risk of mortality by their admission, Apache, diagnoses, age, past medical history, and you add in they either have new depression or worse depression. Their mortality goes up over 50% for the duration of the study. And around 2 years, it starts to level out a little bit. That's a huge escalation in mortality. And again, major depression, 3 to 4 times as likely to occur than PTSD, and that's new or worse depression. I'd be remiss to pretend it doesn't impact our nurses, our physicians, our other clinicians that are part of the team, and the family members of patients. We knew the family stuff for years in pediatrics, where the death of a child has like an 80 or 90% risk of PTSD in a parent. And we knew all of that. But it's important to recall that the DSM-4 for PTSD doesn't include that you experience the trauma yourself. It can be that somebody you love and care for experienced the trauma and told you about it. So family PICS is really increasingly talked about. And of course, we've written, this is Dr. Ketzer, who most of y'all will know, he just retired recently. We wrote an introduction to a pandemic book where we talked about this, right? We had to go into these patients, we waited to intubate them forever, and they'd be kind of able to talk and they'd have COVID and be kind of healthy other than their lungs. And then we'd go in and say, you need a breathing tube and we don't know if you'll live. And do you want to make a call before we put the breathing tube in and talk to people? And it was tragic. I've had to practice this slide a few times because I realized I've got a little touch of the anxiety related to it as well, right? So these things really impact people. So on that really, really happy note, I want to talk a little bit about what we can do about it because it's not all terribly hopeless. And the main thing to remember or take away from this is if we do good medicine, we might be able to prevent these things that then don't improve. So once they happen, the ship sailed and you want to fix it before that happens. The first thing is talk about it. Now, of course, talk about it includes today, right? I come here and now you learn a little bit, but talk about it to patients. This is one state, I think it was Pennsylvania, where they looked at all these hospitals, so including the big hospitals and the small hospitals, academic centers and private. And they just asked a screening question, do you ever tell patients that they're going to struggle after the ICU? And it turns out, we do terribly at this. This is not a surprise. We also know that we have almost no support group infrastructure in the entire United States. There's like a handful of hospitals that offer any sort of recovery, thing for survivors of critical care. And these things, insofar as they're valuable, what they do is they help to normalize it. So again, talking to patients and saying look, you might have nightmares and that's a normal experience and you should talk to somebody about that and maybe get care with regards to our newer PTSD therapies. There's handbooks, you can Google them. So if you forget this talk entirely and this comes up with a family, if you Google ICU Survivor Handbook, this is the first thing that comes up. It's actually a phenomenal handbook, all about what you might experience, how you should deal with it and talk about it. So these things get talked about. After talking about it, it's really crucial to realize that we're really only starting to understand the drugs and therapies that we give and how they impact patients. So obviously all of our brain drugs impact whether they have PTSD, whether they have cognitive dysfunction or brain loss. And we're learning what to do about delirium and how our drugs impact it, and it's really complex. For example, in the CTICU in those early works, the more epi you got, the more PTSD you had. That made sense, right? You're all adrenaline crazy. But that was only for men. When they zeroed it by gender, women were not impacted by epinephrine. But they tried beta blockade, and that only worked for women. And so beta blockade helped, but only for women, and adrenaline was worse, but only for men. Norepi, there's data all over the board in regards to you remember traumatic memories, you create the memory, but then it's much more short-lived, this weird things. Glucocorticoid receptor polymorphisms nearly unanimously predict your rate of PTSD, your risk of it. Right, so if you just take normal polymorphisms that have no functional component and track how often they have PTSD, it's like a 20% step per polymorphism. So we don't understand these things, and we don't know whether it's the drug impacting memory, right? Are we just changing whether you remembered what happened or not? Or is it a drug effect directly on the brain? So we don't really know. But we do know that there are some things we can do that help this again, and these are the bundles. And I have to admit, if you guys know Anila Bhatti, so I share an office with Anila. She looked over my shoulder and goes, "Fuck you, Micah. You're going to talk about the bundles, aren't you?" And all of us feel this way about the bundles because they're this it just felt like a big corporate do this bundle and stop the drugs that you're on, and let's talk about our feeling stuff. And it drove a lot of us really crazy because the bundles are kind of just basic good critical care. And so I want to highlight that the bundles are not these terrible things, but they are really good basic critical care, but they're born of evidence and the outcomes are quite compelling. The bundles, the ABCs of their bundles are listed here. The first one is pain, assess, treat, and manage, and not let patients struggle with discomfort. I want to bring up pain in the ICU because pain in the ICU, we use scores because they're kind of out of it, and all of the scores that exist include ventilator synchrony as part of the assessment. And ventilator synchrony is a problematic thing because that includes the skill of your intensivist, right? So these things are not just pain and controlling pain. There's, how we care for patients. And not only how we care for them for that, but how we address some of the procedural things that happen and how we talk to them. So a big retrospective survey of patients, and all they did is ask, like, what do you remember that hurt? Which procedures were the worst? And it was things like, did you have pain before they did the thing? Right. So like if you're needing an art line, but earlier that day, ortho reduced a fracture, your art line suddenly hurts more. And it's not a little bit more, it hurts drastically more. And similarly, did we actually take the time it takes to give you medicine? And that's really important for us as busy clinicians because we're running around, with our pants on fire. And if you show up and you need to put a chest tube in, really taking the time to talk to the nurse who forgot to grab the medicine, and you could just use a little more lidocaine and let's just get this done, right? That's probably not great for patients. And the most painful procedures was alarming to me because it included art lines. And that's I do these in pre-op, right? These are not big deals. But they didn't zero for numbing people, right? So this idea of just treating your patients like they're human, right? If it's your mom, you'd want lidocaine whether or not they're awake. So just use lidocaine, come on. That sort of basic stuff is really important. But the other thing that's good is how we talk to patients matters. So nocebo communication is how we all interact, and our nurses are trained to interact. Hey, are you hurting? Tell me about that pain you have. You have a huge wound. You need some pain for that horrible, man, that looks like it hurts. Tell me your score. Tell me your pain score. Let's talk about your pain. Pain. That idea, that's called nocebo communication. It's terrible for people. That pain as a vital sign thing is a horrible thing. Obstetrics has done great work with C-section pain and in a fairly standardized group of patients who have fairly standardized outcomes. They know what to expect. What the wound feels like. This really well done study, it's a decade old now, but British Journal of Anesthesia, huge journal in anesthesia world. And all they did was switch how they asked patients about their pain. So instead of saying, hey, do you need medicine for pain? They would say, can I give you more medicine to be comfortable? Can I improve your comfort with a little bit of medication? Instead of saying hey, does your wound hurt? They'd say, hey, your healing wound, do you need medication for your healing wound? And they just adjust, right? It's touchy-feely-ish, but it's fairly straightforward. In the OR, you'll note, if you're ever in the OR with me, you'll notice propofol burning. So pay attention to your anesthesiologist. You'll watch all of us do a bad job of this. But if you say hey, this is gonna hurt, right? You ready for this burning up your arm? You're gonna feel, you'll be asleep after, but just wait, you'll feel this burning, right? It's like saying I'm gonna punch you in the stomach. Are you ready for this, right? We all know it's gonna be worse. If you just change that and say, you're gonna feel sun on your arm, this is gonna be a sunburn. Right? You're going to feel sun, go to a beach somewhere. The amount of patients that jump off the table, it goes down dramatically. So these are really simple things, but they're well validated. And comfort score and pain score are well validated to be perfectly inversely related. So it's a reasonable and well validated thing to simply say, how comfortable are you instead of how much pain are you in? And that'll improve your traumatic memories because half of our traumatic memories are pain related and comfort related. The second part of the bundle is the spontaneous awakening trial. This is the original publication on the spontaneous awakening trial. So it had 15 patients. And so in this 15 patient cohort, which is not many, and I'll validate that, they had these remarkable decrements in length of stay. And it was driven by duration of mechanical ventilation. So you wake people up once a day and you kind of magically realize oh, you're awake and breathing and fine. We should pull the breathing tube out. And they improved mortality with this. What I was most impressed by in this study, previous psychiatric illness, 2 in the control group, so the normal group, more, so 5 in the intervention group, right? So you'd expect the intervention group, they have previous actual psychiatric diagnoses, not SSRIs, but an actual psych visit. And in that group that that got woken up once a day, the intervention group who had 5 versus 2 PTSD history before had no PTSD after. Right, so this is drastically underpowered. You can write it off to a million things, but it's pretty compelling. All their scores also went down of post-traumatic memory. So waking people up is good. If you combine it with a breathing trial, where I put them on an actual ventilator so they're not struggling, put them on pressure support, mortality improves, and it's driven by getting away from intensivists like me. Right, like the faster you can get away from me, the better. And this is not the magic of an awakening trial. It's the magic of remembering that your patient shouldn't be in a coma, right? Like we shouldn't, I think if you go ask anybody on the street, if you're critically ill, do you want to be asleep for the whole thing? They'll say absolutely. But it turns out that's horrible for you. So doing these daily awakening trials, the nurses turn down sedation and they get used to the idea that the patients are awake and that's good. And it's not bad, and I should be in the room and talk to them. This is the RAS score. I make my residents do this on rounds because if you walk through our ICU right now, our average RAS is like -3 to 4. And it comes up every day on every ventilated patient. Every day this week, I'm on service right now. Every patient I have is over-sedated relative to our goal, and it doesn't matter how many times we talk to them. And the reason for that, and of course, our goal includes +1 on a RAS score. And I always make people read this, which is anxious, apprehensive. It's okay to be anxious. You're critically sick. If you're not anxious, that's not normal, right? And that's okay. You don't need medication for a +1. And we see this nationally. It's not just UW. So this is the SPICE trial, which outside of a cool name, is published in New England Journal of Medicine. And this is 3 years old. It was one of our Dexmed trials, like, oh, Dexmed will save the world. And the SPICE trial had deep sedation in 40% of patients, and the entire trial was based on the idea that light sedation was targeted in every single patient. So they failed terribly. And this is percent that got to a -2, which is still below goal. And it's terrible, right? The best 70% at 14 days out. Now there's selection bias here. I won't pretend these aren't the sicker patients that end up sick, but I promise you, it's not all selection bias. So it's a tale of Goldilocks, right? You don't want to be too light and self-extubate, but every time we look at it, we're too deep. And the reason for that is it's really hard to do. Now I'll whine as an anesthesiologist because now you have to listen to me. But MACs are really hard, right? When we do monitored anesthetics, they're way harder than a general anesthetic. And they're harder because patients awake and then they're going to move and that's going to impact how easy it is for y'all, right? So light sedation is a ton of work, right? The risk in the ICU, if you're on, epi and norepi and vaso, and you're an agitated patient who's prone to having, panic attacks and self-extubating. If you imagine doing that as a nurse, that's a ton of work. Now imagine our current nursing climate. We have travelers in all of our ICUs. They don't know who to call if their patient's about to self-extubate. They don't feel comfortable. They don't want it to happen to them. And we also have a ton of young ICU nurses because all our older ones are going off to different fields. And so now imagine you're like 22, 23 years old, and this is your first job, and you're supposed to lightly sedate somebody. You may not even know that light sedation is really that good for you. So it's hard. And on the ventilator side, I give this talk to anesthesia. Those are both ventilator desynchronies that are horrifically uncomfortable that you notice are not alarming the vent and have happened. I think I've caught this in 6 patients so far, and I've had 12 patients intubated this week. So this is like all the time if you look. And so this sort of discomfort, so it's skill related, right? Like doing light sedation isn't easy. It takes a lot of work, and we haven't set up ourselves for success in this way. What instead gets talked about is like what drugs you use. And as I prepared for this talk, I've never been super anti-benzos, but I'm even less anti-benzos now. It's not that I don't think, benzos have some side effects, but the way I think all of us are taught, particularly on the resident level, you guys are probably taught that like benzos are the devil, right? Like these are horrible drugs. You're totally making your patient at risk of delirium. You should stop. But all the work that showed that, almost all of it, is on benzo infusions, right? Which you need sometimes, particularly in neuro ICU more often than I need them. But those were on huge doses of benzos. And the data on it has actually been mixed, and they're associated on all these big meta-analyses. It always includes benzo infusions, and we've never ruled out the confounding by indication. This is a 2015 intensive care medicine publication, and this is really important to read from a 2014 New England Journal. 90 trials have compared, and none of them have showed a real drug benefit. So benzos are not terrible. But there is something about them that is terrible. This is amount of benzos in continuous infusion per day, risk for delirium occurrence the next day. It's not that high, right? And this is 50, this is 2 mgs an hour, right? So yes, you go up with more, but like, 100 to 150, we're talking major escalations in benzo drugs. The main problem with benzos is they're long lasting. So it's not that Medaz is the devil, it's that Medaz lasts forever. How can you wake somebody up if you have an offset of a drug after a drip on the 4.5-hour range on a drip for about a 12-hour infusion gives you a 5-hour offset of benzo. So if you're on it for 2 days, it goes up to like 10 to 16-hour range. So that matters. You're not awake. Dexmedetomidine on the flip side, it got talked about as the savior. It's not as great as you think. So Dexmed, this is meta-analysis of it. You can see there's benefit of Dexmed, right? Like everything's on the left side of the risk ratio, but it of course overlaps. You need a lot of power to benefit. Mainly the safety of Dexmed, that subtle benefit is driven by the fact that you can't do general anesthesia with dexmedetomidine. You can't over-sedate somebody with Dexmed. It's really hard to do. And so there's safety in the fact that the drug kind of sucks. And that's a good thing, right? Like it's great. I love using Dexmed, but it's not that Dexmed is like treating and saving the world from delirium. It's that we force our nursing team, essentially, we force them to do light sedation when we give them a crappy drug to do it with. And so it's not bad, but don't think you're saving the world. The main thing of all of this and the highlight of the talk, and I know I'm actually hitting time, is delirium. So delirium, we do a testing in CAM ICU. It is validated in the neuro ICU if you ask the nurses after 2 days of their initial brain injury. And it's sometimes undersensitive, sometimes oversensitive, but in people that do CAM ICUs, if you ask them 2 days into the hospital stay, they can call it right. We have a bunch of risk factors. The biggest one is increased sedation. And then of course, tying people down, holding them there forever. But if we know that, we can decrease the incidence. And Dr. Dre is an easy acronym. So what diseases? Delirium can be your first sign of infection, but it can be over volume, hypovolemia. And then drugs, of course, we want to lighten our sedation up and then make it quiet and dark at night and daytime bright. That is not done as well as we hope. Our drugs impact it, but the core thing is that delirium is an injury to the brain that doesn't get better after. So when you see it, don't blow it off anymore. You may not be able to fix it, but you should at least address the things you can. Hey, is it actually dark and quiet at night, or do we have our monitors blaring and the nurses are in the room talking too much? Is it daytime and the nurses are out of the room talking too much and need to be in the room? Right, this is a ton to ask of them, but it's really important. All right, exercise and mobility, I'll skip over. I can tell you the bundle compliance, the more you do, which has a selection bias, right? Like getting patients to do all this stuff means that they're not near death. But if you do it, their outcomes are better. All right, so PICS impacts a lot of patients. We don't talk about it enough. And I'll leave you with 3 real take-home points. The first is use less drugs. Wake people up, talk to them, orient them, and use less drugs. That's applicable to the neuro ICU as much as it is everywhere else. Delirium is urgent and testable. I know it's way harder than I'll ever admit in a TBI population. But if you take them and you kind of know their baseline for 2 days every time that it's tested, so if you are, and you have to rely on the nurse because they're there so often, they can tell you that this might be delirium, and then you should address immediately what to do to prevent that. And good basic bundles, orienting patients and less drugs is really helpful. I didn't leave tons of times for questions, but I really appreciate your time. And I will take questions.
Tour de force. Thank you. It is fascinating. Sometimes your colleagues will teach you this. There's a very famous neurosurgeon who spent a month in the ICU and came back normal, was head of every organization, chairman of major Western couple institutions. And if you knew him well, he'd say, yes, I'm doing this, I'm doing that, but I cannot think the way I did before I was in ICU. I used to be able to see solutions, come up with kind of ideas. He could grunt out the work, but he wasn't the same. Very good. Question.
This is a practical question. Do you ever give this talk to your nursing teams?
I invited them when I gave it a few weeks ago, and then we have a handful of things rolling out for UW that I'm helping lead, not only putting things in Discharge Navigator for primary care clinicians to kind of understand and deal with it longitudinally, but also to our nurses. The nursing oriented speech, a lot of this, it's not nurse bashing to say, like there might be being too loud. What they do is really, really hard, and we're asking young, less trained or less comfortable people to do it, and that's really wrong. So really who it should be given to, our experienced nurses all know this stuff and they're really good at it, right? So who we should be giving it to is really the leadership of UW, because you cannot rely on travel nurses that succeed longitudinally in an ICU environment. It's too hard. And you can't max out patient ratios in an ICU and succeed longitudinally for patients. Your short-term outcomes will be fine, but not long. That'd be nice. I think it's probably the only way they would listen to me, pretend to listen to me. So I always feel for them, and I'm of course close to all our nursing colleagues in my ICUs. But what they do is really hard, and what we're asking them to do to fix this is really, really hard.
I think that's a really important point. Team is complete. Need your support. It's hard.
Yeah.
Especially for
and it's skilled labor too. Yes.
And so we have a speculative hypothesis. We've been looking a little bit post-operative delirium and connecting it to the clearance systems of the brain. There's been a kind of renewed emphasis on the lymphatic system, the ninja lymphatic system, and its role during sleep. And it's been connected to things such as norepinephrine antagonists, respiration, movement. And dexamethasone has also been connected to increasing clearance through the lymphatic pathway.
Oh, interesting. I didn't know that.
Yeah. So when I saw all this, like all of this kind of connects in a really interesting way. I'm just curious from your perspective, looking at this, I've seen two papers that are essentially speculating that there's specifically the lymphatic pathway may be impacted by both the drugs that are used as well as essentially long periods of being sedentary for both not doing the muscle movement, anything that changes respiration also changes it. Have you seen a lot of connections in the lit that you looked at between the clearance systems of the brain and treatment?
So my learning on it as an anesthesia-focused person is learning that the entire endocannabinoid system is very complex, and all of our memory systems are important. And I've never looked at clearance. What I've looked at is each drug impact on it. So on the front side, like I push this drug. So I can't speak to that. I can speak to even in the intensive care arena, the increased knowledge that the lymphatic system, even peripherally, is way more important than we all learned in our training.
That's the other thing.
Hugely important.
Alveolar system, if you're not moving, then you have less transport.
Yeah.
Get rid of that.
Yeah. Yeah. That makes a lot of sense, but I can't say I know much about it on the lymphatic side. I know about it in the extremities because I have fights with vascular surgery about it. But don't we all? What other questions?
Micah, you didn't talk about global inflammation as a cause of a lot of this stuff. Is this something that you have any information on?
How much of a role does global inflammation play?
Huge role. So when we look at severity scores of illness, so SOFA score or initial Apache score, it impacts cognitive outcomes and muscle outcomes more than it does the psychiatric outcomes. But the cognitive outcomes are impacted. The strength, muscle, and nerve outcomes are most impacted by the inflammatory process. And that's increasingly recognized to be a mitochondrial problem, right? So the oxidative stress phenomenon at the mitochondrial level. So that has big brain and spine implications. But the cognitive things are predicted reasonably by SOFA score, but not the psychiatric outcomes. The brain ICU study I should highlight, again, those were actually weirdly not that sick of patients. So that huge decrement in IQ, their median vent duration, I think, was like 3 days, 2 to 3 days. It was very short. All right, I appreciate everybody's time. Thank you very much.